Hello, everyone. We welcome you to today's session. We have named it as Radiology Updates in Body Imaging with Dr. Ameya Kulkarni. Ameya is a dear friend and deeply inclined towards academics as well as research, and a very keen radiologist as well with keen interest in body imaging. He agreed to take few topics for our residents he wanted to. So, but we thought that why only for few people? And why not to keep for everyone, for everyone's benefit. So thank you, Ameya, for taking out time for taking these updates for all the Indian Radiologist subscribers and members. So as you know, dear friends, Indian Radiologists have been working hard towards these updates and bringing in education right up to your doorsteps on your mobile phones, on your laptops, with all these online events ongoing since last few years. We have been doing journal clubs, we have been doing master classes, as well as dedicated 3 to 5 days learning programs on ultrasound, CT based studies, as well as on MR. So we have our breast imaging masterclass, which was a great success last year. And even this year, we are receiving registrations in good numbers. Registrations are still on, and next Sunday we are going to have this masterclass. So please do register. It's going to cover basics and advances in breast imaging, including all the modalities which are currently in use, as well as upcoming modalities by experts on national as well as international platforms. We do have papers and posters submission as well, and MMC credit points for the same. The registration links will be shared soon on the chat box. Kindly register and hope we meet next Sunday with breast imaging masterclass. We are coming up with the 21st MRI teaching course, which is something which is already famous and much awaited event amongst all the budding radiologists. It's going to be an extensive 5-day course, which will be hybrid. That is, we're going to have sessions online as well as 2 days on site. So please be a part of it. It's in August this year, and registration links will be shared soon. It will be covering basics like anatomy and physics of MRI, as well as advances into neuroimaging, musculoskeletal imaging, as well as body imaging. We have kept a very attractive offer for registration, as you can see on your screen. And please do take benefit of it. We have MMC credit points applied for and papers and poster submissions with last date on 31st of July. We have more of these upcoming events like SONOBUZZ, CTBUZZ, an MRI teaching course, which I already mentioned about. Thankful to the organizing team, the core members, Dr. Deepak Patkar, Dr. Sanjeev Mani, Dr. Jignesh Thakkar, and Dr. Shailendra Singh, who have been taking efforts and time out of their busy schedule to bring up all these programs. I'm also thankful to my colleague, Dr. Gauri Ahuja, as well as Mamta Patkar ma'am for all their efforts. With this, we come to today's session by Dr. Ameya Kulkarni. He has also been kind and was associated with us for the journal club as well. And he took a wonderful journal club session on body imaging where he spoke about the Bosniak classification of cystic renal masses. So he's going to take over a few weekends, important 6 to 7 body imaging topics. So stay tuned, friends. And Ameya is staff radiologist at Zuravinsky Hospital of Hamilton Health Sciences and assistant professor at McMaster University. His key specialty areas are breast and body imaging. His research interests are radiomics, body and breast imaging, and he's also presently a fellowship contender in breast and cross-sectional imaging at McMaster University, Hamilton, Canada. We welcome you, Ameya, and just landed yesterday night and you're still with us. So thank you for that. Over to you.
Thank you so much for the kind introduction, Nikusha, and welcome everyone for this teaching session by Indian Radiologist. It's going to be an interactive session today. So we will have lots of questions. There will be some quiz-based questions. Much of this talk is based on lots of images. So please make sure that you pay attention to all of those. At any time, if you have any question for any sections of this presentation, you can probably just ask about an individual case as we go through them and just type that question in the chat feature. If you have any specific question about any specific slide which talks about certain points of this IOTA classification system, then just type them down. At the end of session, we'll go back to those slides or we'll try to discuss them so that we clear most of them today. So without waiting any further, let me share my screen and start the presentation. So I hope everybody is able to see the screen.
Yes, your screen is visible.
Okay.
Yeah.
All right. So essentially, what we're going to talk today is what led to development of the much discussed and much talked ORADs these days. So it all started with these IOTA philosophy, which was built in much of the studies in Europe, and we'll basically build on those things so that eventually, as Mitusha discussed about, we will head to the core ORADs concepts sometime in the future. So the goals I will discuss in the next slide. So basically disclosures, I don't have any financial relevant disclosures. These are the acknowledgements of my amazing colleagues who helped me put together this presentation. This was presented at 2020 RSNA annual meeting, and it is recently published in Radiographics as a Radiographics Essential publication. Okay, so we're going to start with the first question here. So some pre-session or pre-seminar test. So the question is, which of these is a benign lesion? Do you think it is A, it is B, it is C, or it is D? So if you want, you can just type your answers in the Q&A or chat session here, or you can, if you're using YouTube, you can just type it there as well. So you can basically just type your answers, and I'll be able to go to them. So what do you think? Is it lesion A, lesion B, or C or D? Which of these you feel is benign? So maybe I'll give a few seconds. And remember, I'm not disclosing any of the descriptors of this lesion. I'm just showing you some pictures. Lesion A, as you can see, there's a transvaginal ultrasound with a 2D color Doppler. And lesion B is just a grayscale transvaginal ultrasound with the lesion in the long axis. Lesion C shows you that there is a lesion, again, on transvaginal grayscale ultrasound. And lesion D is a pretty large appearing lesion, again, on transvaginal ultrasound, only in grayscale. So I'm starting to see some answers here. So the first answer is all, and many of you are answering all. So this is a very good assessment from all of you. Excellent. So we can start with the next question now. So the next question is question number 2. How do you define this abnormality? So I know it's difficult to type this out, but for those of you who have been assessing lots of adnexal masses and do lots of ultrasound scans, they can just type it. It may be pretty easy for it just to type. I mean, what do you think? Do you describe as a just complex lesion, complicated lesion, or do you want to use any other descriptors? How do you want to talk about this abnormality? So let's just give a couple of seconds here just to wait and see if anybody wants to answer. So this example is just to reiterate the concept of IOTA and how we want to discuss about that in the next few slides. So for those who have been using or trying to assess adnexal lesions with ultrasound, just type a quick response to this question. If you feel that it's just complex, complicated, or is there any other descriptor that you want to use here? So I'm starting to see a few answers here. Complex, okay, that's really fair. And maybe let me just quickly check if there's anything coming up on the YouTube session here as well. So there are a few options for the previous answer, but anyways, we'll wait. So complicated, okay. All right, so maybe we'll go, okay, so there's one answer on YouTube. It says multiseptated, and that's actually a very good descriptor here. Well-defined complex cystic lesion with thick septa. Okay, so thanks for answering those questions. So it's really important to understand these concepts and how these descriptors can change your assessment. So I'm going to come back to these questions again at the end of the session today, okay? The next question here is, which of these is a definite malignant neoplasm? Do you think it is A, B, C, or D? So if you feel strong about any of this, you can just type it here. And in the meantime, there is one answer in the session here called as multilocular multiseptated cyst with low-level echoes, and that's a really good job, actually. Thanks for answering that. So we are getting all sorts of answers here. Option number B, which is this lesion. Option number C, option number D, and option number A. So we're getting lots of options here, as which of these lesions is definitely cancerous or malignant. And we are also getting some options on the YouTube talking about lesion A. Okay, so remember these images well, and then we will head to our presentation now. So the introduction of the session is basically just to understand the key lexicon terms, because that is really, really important when you're assigning any lesion categories to any of the types here. I'm just going to quickly turn off my video here just to make sure it doesn't superimpose on what I'm trying to discuss. Okay, yeah. Then next is to become familiar with IOTA, International Ovarian Tumor Analysis Group's 10 simple rules. That's the basis of this talk today. Then number 3 is to apply these rules and assess how we can classify lesions. So remember, this session is going to be a pretty imaging-based session. So once we go through the basics, we are going to discuss some cases and where you will be able to apply the B and M rules. So in terms of assessment of adnexal lesions, as you would have seen in some of the question answers now, it is essentially a management dilemma. So lesions, both benign and malignant lesions, they just get described as complicated or complex lesions at ultrasound. Well, that does not help anyone. That does not help the sonographer, and that does not also help the surgeon. What to do with them? Are they cancerous or not? Should we do surgery or should we just follow up? Should we refer to an MRI, get further assessment? Should we do any blood work? All of those questions are unanswered if the lesions are just explained as complicated or complex on ultrasound. So what happened because of these dilemmas is it can basically cause suboptimal classification, which essentially puts a patient into increased follow-up imaging when it is not needed. It can delay oncologic referral because things are just being worked up. And essentially for malignant lesions, that is a very, very important concept to remember, that we should not do any kind of delay in oncologic referral by just adding more steps when it is not needed, or even oophorectomy for even benign lesions. And this is something which you definitely don't want to do. Why would somebody want a surgery and put through the risk of anesthesia and getting the uterus and adnexa out when the lesion is just going to be benign? So International Ovarian Tumor Analysis, henceforth we're going to just refer to as IOTA. So they came up with 10 simple rules to classify a series of benign and malignant lesions just by using ultrasound features. Because remember, ultrasound is going to be the first imaging modality which most of these women are going to undergo. That's going to be the baseline, and that is going to decide the future steps. To understand this, we are going to go to terms and definitions as described by Timmerman et al. In 2000. But before that, let's hit a few other core concepts here. So in terms of simple rules, there are 5 B or benign rules, and there are 5 M or malignant rules. So remember, so 5 B for benign and M for malignant. So just add them, become 10 rules. So they are derived from a multi-center analysis of almost over 1,200 surgically excised adnexal masses. And these were around 1,066 patients. And they found that the sensitivity and specificity of these rules was almost 93 and 90% respectively. So what did they talk about in terms of ultrasound assessment? So they talked about echogenicity, they talked about cystic fluid contents, they talked about wall irregularities, they talked about locules and solid components as well as ascites. And essentially what happens now is that we are trying to, or they were trying to develop a lexicon. So lexicon is just in-depth knowledge of terminology and language to describe certain branch of science. Like here, it just talks about adnexal lesions. So for example, when we talk complex, it can include whole sorts of things, including a multilocular solid ovarian neoplasm. It may have thick irregular septations. It could just mean a pure solid irregular mass, as well as some cysts with multilocular cystic appearance and low-level echo. So it's just so variable as you think in your head if you talk about just complex or complicated lesions. But if I tell you that this is a unilocular simple cyst, you exactly know what I'm talking about. If I tell you, if I'm talking about a multilocular cyst with solid components or papillary projections, then you exactly know what I'm talking about. But I could just say complex lesion and just run away with it, but nobody would know what I'm talking about. So that's the whole concept of lexicon, which was developed in 2000 and published in 2000 by Timmerman et al. So to understand that, I just created this like a small graphic representation, and let's just talk about that. So I'm going to do a few drawings here just to give you an idea of what we're talking about. So just imagine that these black oval structures here are just the cystic masses. So the key concepts hover around unilocular and multilocular cysts here. So remember, both of these can be with or without solid components. Whenever you see solid components, you can just call it as unilocular solid cyst. And whenever you see just a fluid component, you just call it unilocular cyst, and do the same for multilocular cysts. So in case of unilocular cysts, remember it can have a single incomplete septation. So something like this, it can still be called unilocular cyst. A normal ovary surrounding the unilocular cyst. Remember, don't measure normal ovarian tissue as a solid component. So for example, you may have seen this appearance quite a few times. So remember that everything outside of this red line is the ovarian parenchyma. So you will have your normal ovarian follicles which are lying there. So don't include this as solid lesion. This is just the normal ovarian parenchyma. So the problem starts when you start to see wall irregularities or a papillary projection or solid papillary projection. So what is a solid papillary projection? You start to see this hump of soft tissue which is present along the walls of this lesion. And that is when you start to get concerned about. It's going to be suspicious from that point onwards. Whenever you see solid tissue or septations, you have to turn on your color Doppler, and we'll talk about that in the next slide. Then the next component here is multilocular cyst. So again, multilocular cyst by definition is any ovarian cystic neoplasm which has at least one thin complete septation, but obviously it can have multiple other variations such as this. Even this appearance, you have to call it as a multilocular cyst. Now, even these lesions can have solid papillary projections or solid components. So you can have the component along the septations. You can have these solid papillary projections along the walls. The wall may be irregular as well. So again, when you're evaluating these, try to exclude the normal ovary and parenchyma which can be present at the periphery, as that is not a true solid component. It's just benign or normal appearing ovarian tissues. Then some important things to exclude. Don't include mucin balls or Rokitansky nodules when you're measuring solid components. Those lesions are essentially benign, so don't include them in your measurement or descriptors. Okay, so let me get to the next slide here. All right, so now with adding all of these permutations and definitions, we are left with 6 options. Number 1 is unilocular cyst. Number 2 is unilocular cyst with unilocular solid cyst. 3 is multilocular cyst. 4 will be your multilocular solid cysts. So we discussed about these. The next will be a purely solid lesion, which is more than 80% of a cystic mass. So you'll have a very small cystic component in these ones. And the last one is not classifiable. So not classifiable by ultrasound can mean a whole lot of different things. Essentially, it can be that the lesion is too large to capture an ultrasound. Maybe it's a big mass with lots of echoes which prevent you from assessing all the wall characteristics and all the lesions present along the wall. And it can also be from patient factors when the ultrasound is just not optimal. Those are the situations when you have to definitely resort to additional imaging modalities. Now, when we discuss about ORADs, basically this section gives you a better management guidelines. So this IOTA terms and definitions served as a baseline or the basis for development of lexicon and ORAD. So it is very important to understand this concept. How to measure the papillary projections and the wall thickness. So imagine if you have an ovarian lesion like this. So I borrowed this graphics from this paper where it talks about terms and definitions. So you basically have to draw a tangential line and measure the height of the papillary projections from this tangential line. And in this case, if the lesion was, or papillary projections were along this wall, you just have to measure the maximum height of it. So if it is more than 3 millimeters, as shown in this graphic, that is when you call it as solid papillary projections. For anything which is less than 3 millimeters, it's going to turn out to be just wall irregularity. So remember, it is important to understand lexicon and the recommended measurement guidelines, because if you don't measure them correctly, say you just have like this oblique diagonal measurement and say that, okay, now it's more than 3 millimeters, it won't classify to be a solid papillary projection because you're not measuring it in the right way. It has to be a perpendicular line to the wall of the ovary, or it has to be a perpendicular line to a tangential line drawn where the convex protrusion is present within a hump of normal appearing liver, normal appearing ovary, or normal appearing tissue. So it's very important to understand these concepts. Now, they also talk about a very significant finding, which we always look for, whether the lesion is vascular or not. Because again, that is a subjective assessment. But even in that subjective assessment, you can still classify into 4 categories as color score of 1, 2, 3, and 4. So 1 and 4 are pretty easy. 1 is when you don't have any vascularity in the lesion. And 4 is when the vascularity is so significant that the entire thing just lights up. it becomes difficult to classify 3 and 4. 3 is essentially when there is minimal or mild vascularity, and 4 is going to be 3 is going to be your moderate. So 2 and 3 are going to be difficult, but 1 and 4 are pretty straightforward. So as we all know, ultrasound is a very operator dependent tool. So how to ensure that the color Doppler settings on my device are same as yours, because I may have a totally different PRF and a totally different velocity. And I'll say that, okay, this lesion is 1 when it is actually a vascular lesion. And vice versa, you may have turned on power Doppler and say that, oh, this lesion is highly vascular. So to minimize that, to minimize those errors, they also recommend what should be the color Doppler settings to have a consistent color score across the board. So the PRF has to be at least around 0.3, and the velocity has to be between 3 to 6 centimeter per second. That is when you are going to standardize your color Doppler measurement. So remember that the key concept here is to standardize, to make sure that the lesions are assessed consistently, and that is when you will be able to recommend, that is when you're going to be recommending appropriate category to this lesion. So what are these rules? So this is just a table which I derived basically from the paper which was published by the IOTA group. So you have, as we discussed, you have 5 M rules and 5 B rules. So remember, M is going to be for malignant and B is going to be for benign. So you have rules such as in the malignant class, you have going to have rules such as irregular solid tumor, presence of ascites, at least 4 papillary projections, irregular multilocular solid tumor of more than or equal to 10 centimeters, and very strong blood flow. So color score of 4. These are your 5 M rules. So now after we discuss the lexicon, now you must be understanding most of these terminologies. If not, you can always refer back to that paper. It's very, very useful to understand that. What are the B rules? Number 1, unilocular cyst. Number 2, presence of any solid components. Largest solid component is going to be less than 7 millimeter. And then presence of acoustic shadows. So all the posterior shadowing that you can see in lesions with dermoids. Then smooth multilocular tumor, but it is less than 10 centimeters, and there is no blood flow, which means that a color score of 1. So remember, they are not talking about color score of 2 and 3, because even they know that it is hard to differentiate between 2. And whenever you have 2 variables which are very closely spaced to one another, it increases the subjective feeling, and that just complicates the classification algorithm. So that's why they have included color score of 4 and color score of 1 here. Okay, so now you understand this. How do we apply them? So say you're doing ultrasound and you see 1 or more M rules, but no B rules, then the lesion can safely be classified as malignant. If you see 1 or more B rules, but no M rules, then it can be classified as benign. If both of these rules apply, then it cannot be classified according to the algorithm. You need to address this in some way, maybe do an MR, maybe repeat the ultrasound at an expert's opinion. And again, the same thing, if none of these apply, again, it cannot be classified according to IOTA classification. And you may have to think about, are you really looking at an adnexal lesion, or if there's something else going on here? Okay, so it's just a small pictorial representation of what each of these categories means. So again, on the top, you can see 5 B rules, and on the bottom, you can see 5 M rules. So let's start with the M ones, because they are the most concerning ones. So number 1 is irregular solid tumors. As you can see that there's this large solid irregular lesion, which is projecting along the wall of this ovarian mass. So remember, papillary projections, if they grow too big, essentially they're going to turn out to be a irregular solid tumor, right? And then presence of ascites. So if you have a large ovarian mass, but presence of ascites, as you can see here in the asterisk, that is one of the factors which point towards M2 rule, because remember, ovarian neoplasms can cause ascites, peritoneal lesions, and peritoneal carcinomatosis. M3 is at least 4 papillary projections. As you can see in this lesion, I'm pretty sure it's really small, so it's hard to figure that out, but you can see these septations, which are making it a multilocular cystic mass with solid components. So all these echogenic areas that you see here, not echogenic per se, but like solid appearing lesions, these are nothing but papillary projections, which are along the septation. So remember, the papillary projections can be along the wall as well as along these septations. So here you're seeing them along the septations. So at least 4 of them are present. You give that as a M rule. Then irregular multilocular solid tumor with largest diameter of more than 10 centimeters. So this is a very large. So as you can see, this picture is transvaginal ultrasound, right? But this is just a convex probe put in the lower pelvis of the patient's abdomen. And you see this large tumor in the pelvis, more than 10 centimeters. And it's a multilocular solid tumor with irregular solid component there. M5 is very strong color. So you can see this solid ovarian neoplasm, and you see this very high vascularity within this lesion. The B rules again, unilocular cystic lesion or unilocular cyst, very simple to assess. Presence of solid components with largest diameter of less than 7 millimeters. So as you can see that there's a small papillary projections here, so less than 3 millimeters. So remember, it has to be more than 3 to call it as a papillary projection, right? Then presence of acoustic shadowing. So you can see that there is these echogenic lesions, but you see this posterior shadowing. So you see most of these with dermoid, but there is a mimicker, great mimicker, and we're going to talk about that in one of the cases here. Then smooth multilocular tumor with largest diameter of less than 10 centimeters. So you can see that these are smooth walls, just multilocular cyst, but there are no papillary projections and no blood flow at all within the septations or the papillary projections. It gives a color score of 1. So these are just the lexicon which define the 10 simple rules. Okay, so where does IOTA fit with ORADs? Because all of us have been started to use ORADs and have been like somebody will ask you that, okay, what is the ORADs category of this lesion? You gave me a report that is the 10 or 15 centimeter mass, but what is the ORADs category? So before we discuss about ORADs, it is important to understand the concepts of IOTA because that is where the lexicon of ORADs is taken from. So the original descriptors here essentially led to ORADs, and there is another IOTA adnex model which basically predicts the mathematic risk of malignancy. So if you don't know about that, you can just Google it out. If you are doing an ultrasound of the adnexal lesion, if you see the mass, you can go to that calculator and predict the risk of malignancy if you know certain clinical and biochemical features of that patient as well. So ORAD's ultrasound, so what does it do in addition to IOTA? It not only specifies characteristics of common benign or malignant ovarian lesions, but it also provides management recommendations. So remember, just like BIRADS, the same thing is in ORADs. It provides you some management recommendation. What should you do next? Should we follow up, do an MRI, or just excise and recommend to surgery? So those are essentially what you get more in ORADs in addition to IOTA. Then both the models, as we discussed here, the IOTA adnex as well as ORADs, they are complementary and can be used as a part of decision-making process in the evaluation and management of adnexal lesions. So for example, in IOTA adnex, you can add a certain biochemical markers, CA125. You can ask the patient certain risk factors and put all of that information to create the additional findings. So what are the standard pathologies that you come across when you're doing ultrasound? So you see normal ovaries, benign findings like follicle, hemorrhagic cyst, or a corpus luteum cyst, including functional cysts. You can see benign tumors as cystadenomas, you will see borderline tumors, and you will see invasive tumors. So these lexicon terminologies which we discussed right now, they will help you assess multiple features of all of these pathologies. And the 10 simple rules will assess to see if it falls under this category or anything else. The lesions which cannot be classified, they may fall under a various mixture of other types of lesions. The most important part of this presentation, we have this case library here where we are going to discuss about 8 different cases and try to see if we can apply these simple rules. So for the sake of having a better visibility of these images, I have turned off my video. I'll turn it on at the end of the session. So let's start with case number 1. So I have given you 3 static ultrasound images. Image number 1, as you see on the left side, is a transabdominal grayscale ultrasound. You see a lesion, and definitely it looks like a cystic lesion, and I have turned on color Doppler to show that there is no vascularity along these septations as well as the wall. In some other part of this lesion, you see these, you definitely see these low-level echoes, but there's a suspicion that the patient might have this irregular solid component. And then you see this asterisk mark. It is nothing but the benign ovarian stroma, which is pushed to the periphery, but much of the portion of the solid component that we were suspecting here, it does not show any color Doppler. So in your head, now you start to assess, okay, what M and B rule I can apply to this lesion. So in terms of the descriptor, you see here, like it's a 21 centimeter lesion. It's a multilocular cystic mass. There is no blood flow in any of the septations here, and the patient is premenopausal with CA125 or 63 Ku per liter. She presented to ED with pelvic pain, and that is why the patient had this ultrasound. So obviously we see that it doesn't have certain, or it does have certain features. For example, here it does not have blood flow, so you can safely assign a color score of 1. It is definitely not a unilocular cyst, definitely has something which looks more than 7 millimeters. So none of these other B rules are going to apply here. So you have at least one B rule which you can straight away apply to this lesion. Now, what M rules you can apply, or whether you can apply any one of them. So you see this irregular solid component here, right? So it's going to have at least this M rule, so which means that it's an irregular multilocular solid tumor, and the lesion is more than 20, it's a 21 centimeter lesion, so it's more than 10 centimeters. So you can safely apply this M rule. We did not see any ascites, and we did not see a typical solid irregular tumor, and there were no other criteria which you could meet, definitely not the color score. So you have at least one M rule and at least one B rule, so which puts under a class of lesions which cannot be classified using these terminologies. So essentially the patient, since the patient was also in pain, they also did a CT abdomen and pelvis. And all that you see here on CT is that there's a large abdominal pelvic cystic neoplasm, as you can see here. It's pretty large, going all the way to the epigastrium. And you were seeing this portion on the ultrasound in terms of those multilocular or septations in the lesion. The patient underwent a oophorectomy because of the increased CA-125 levels just above the baseline, and they did perform iota index model or assessment of the patient other risk factors, and they excised it out. So rightly, this lesion turned out to be serous borderline ovarian tumor. So it was not just plain simple benign cystadenoma, it was a borderline tumor. So what is the key point here? So quick classification tool using this 10 simple rules can help you assess, make a decision whether the lesion is benign, malignant, or inconclusive. If it is inconclusive, you definitely assess it further to CA-125, refer it to gynae oncology services, and assess if they want to take it out. Look at other risk factor of the patient, whether the patient has any BRCA mutations, because remember, those patients are going to have higher risk of ovarian malignancies. So all of those factors are going to play a key role in making a decision at the end of the day, but ultrasound will at least help you assess whether this is straight away a malignant lesion or not, or straight away a benign lesion, which does not need further follow-up. So the next case here, so case number 2 is going to be, I have this cine loop here. I'm not sure how it's going to play on your screen, but let me just play it anyways. In the meantime, you can see one of the static images of this lesion here. So let's just play the cine loop. So it's just a transabdominal ultrasound. You see as the cine loop sweeps through this lesion, you see this large irregular solid component which is present at one of the walls of this lesion, and it also shows some amount of vascularity on Doppler assessment. So visibly, again, it is fairly easy to say here it's not definitely 1, and it is not going to be definitely a color score of 4. So it's neither of those. So that helps you close the loop here with the 10 rules. But whether it is 2 or 3, that is the harder thing to discuss about. And that's the reason why I was telling you that those 2 and 3 are not included in this rules, because the goal is to make them simple. The rules should be simple. So now we looked at the cine loop, and now what we can think here is that this lesion definitely is pretty large. It was a 12 centimeter mass. So again, in terms of size, it is not going to be less than 2 here. So you're going to be more than 10 centimeter and see if it has irregular multilocular solid tumor. So the answer is yes, it is irregular multilocular solid tumor. And this lesion does not have any of the B rules. So we have at least one M rule that applies in this case, right? And once that happens, you can just classify this lesion as a malignant lesion. So let's see what it turned out to be. So on final histopathology, it was a stage 4 mucinous adenocarcinoma. As you can see, this patient underwent a CT, which was performed as a part of staging protocol. So remember, in this case, once you are fairly confident on ultrasound in suggesting that it's going to be malignant, MR may or may not help you to have any further additional information. If you're not sure about what to do next, then definitely yes, MR will help. But in this case, the imaging features were pretty concerning for a lesion with malignant feature. So this turned out to be stage 4 mucinous carcinoma, and you can see that this solid component was the one which you saw here on the ultrasound, and there was no peritoneal disease or no abdominal pelvic ascites. So these rules will increase your confidence of stating the likelihood of a lesion being malignant, and just expedite referral to gynecologic oncology services for further management. On histopathology, it looks something like this. Like I'm not a pathologist, but just to give you an idea of what these mucinous neoplasms with higher grade are going to look like. So you definitely see that this is disorderly arrangement of glands. There are lots of papillary projections that are developing here inside it, and you can obviously see mucin. Sometimes you can see cribriform appearance of this structure, so something similar to DCIs that you can get, like you see these lots of hole-like areas, which are nothing but new ductal gland formation, which is forming in the lesion. Let's go to the next one. So case number 3. I have given you a sagittal grayscale ultrasound in this patient who is perimenopausal. And so look at this, like this is transabdominal assessment, right? So it's a pretty large lesion. So you can see here, it's an 18 centimeter left adnexal cyst or left adnexal lesion. And this was one of the questions that I asked you. So the correct way of describing will be a multilocular cyst with low level echoes, as one of you had rightly pointed out. Now, the problem here is that the patient had CA 125 or 458, which was obviously done after the fact. But on color Doppler assessment, you can see along the septations that there is very strong vascularity. It can be subjective. In this case, it was classified as category 3, but that's just something which can cause a little bit of objective variation. There are some papers which describe about inter-observer agreement about color score, and between one category to the adjacent one, it's a little bit difficult to do that. So anyways, so you see this vascularity, and further inferiorly, when we did the transvaginal ultrasound, you can see that the patient had these papillary projections, which were kind of, some of them measured up to 7 millimeters. So this is something which is really important to understand. Like the reason why I'm reiterating this facts is like there are certain numbers which help you assign the B and M rules. So these projections were kind of around that 7 millimeter mark. So now what you see here, that the patient has solid components, but they were all less than 7 millimeters. The papillary projection was less than 7 millimeters. And this patient had this large multilocular cyst, but there were at least 4 papillary projections. So now we have a mixture of 2 findings here, right? So you have these things where there are at least 4 papillary projections, but each projection or the solid component is less than 7 millimeters. So that kind of creates a little bit of a challenge here. So you have one B rule and one M rule. So essentially the lesion will not be classified according to these simple rules. In this case, you obviously have to resort to additional tests, and that is why the CA 125 was done. It showed a very, very elevated CA 125. The patient had an outside MR, which I did not have access to. So I'm just showing you this coronal CT image here. So you can obviously see that the urinary bladder is kind of displaced inferiorly, and there is a large pelvic mass, and it shows these enhancing septations or septa. And one of the papillary projections that you can see here is pretty large, and probably this was not accounted for on the ultrasound. So remember, ultrasound is going to have a little bit of limitation for assessing large ovarian lesions and patients who are also of large body habitus, just because of poor penetration. So in this case, the final pathology turned out to be a poorly differentiated mucinous adenocarcinoma. So it is important to understand the significance of lesions that cannot be classified using this tool, because again, remember, lesions that cannot be classified, they can end up being just totally benign lesions, or they can also be completely malignant. So unless proven otherwise, you cannot just simply consider them as benign. They have to be further worked up. Let's go to the next one. So fourth case here, again, you have 2 ultrasound images. So one on the left side of the screen is just an axial grayscale ultrasound using convex probe here. You can see that the patient has these septations, and the septations here appear that they are irregular. So now you see this, this is just an axial grayscale ultrasound which shows a woman who is in her 30s. It is a large 11 centimeter left adnexal multilocular cystic lesion. It is filled with low level echoes, and it definitely had these irregular septations or wall irregularity and septal irregularity, but it also had some of those areas which appeared as solid components. So this lesion looked pretty suspicious on ultrasound at the time of performing the ultrasound, and plus we did not have any priors to compare. We turned on the color Doppler, and there was no vascularity within the solid components as well as the septations. So now what we are left with, we have a lesion which is more than 10 centimeter, looks like an irregular solid tumor, and the lesion also appears to have no blood flow. So there are 2 different sets of rules happening here. Number 1 is 1M rule, and the other is 1B rule. So again, the lesion cannot be classified using this tool now. So final histopathology on this patient was endometriotic cyst. So let's see what we learned from this lesion. So we did the MR for this patient. So this is axial post-contrast pelvic MRI T1 fat suppressed image. You definitely see these septations. Plus you also see these arrows pointing towards some of the enhancing papillary projections or solid components. So remember, the endometriomas can appear quite complex. So apologize if I'm using complex term here, but this complex has nothing to do with the lexicon. It is just to show you the nature of this lesion. They can be fairly challenging to assess, and it may show suspicious features on MR. For example, the enhancement. Whenever you see the enhancement, remember, if any one of you who has started using MRI ORADs, you have to grade the assessment based on comparison with the myometrium and see if it is more or less enhancing. We are going to talk about that sometime in the future, but just some food for thought. Endometrioid and clear cell tumors, they remain as a differential diagnosis in these cases, especially who have had a history of endometrioma. And usually MRI is the next step. And even that may remain equivocal, and the patients usually may end up getting a surgical excision. In this patient, the CA125 was 53 Ku per liter. So remember, these values are going to help you assess INDEX model as well. Okay, so let's look at the next case here. So the next case is, again, we have two ultrasound images here of one patient with an adnexal mass. So you can see this axial grayscale ultrasound and a color Doppler, which shows you that there is a lesion, which shows these echogenic components, right? So right off the bat, you can say, oh yeah, the patient has echogenic components with some, maybe some of them show posterior shadowing. Let's search for those. So you search and rightly, you can find some of those which show posterior shadowing. So you right away apply this B3 category here. But now what is happening in addition to this is that on starting color Doppler, again, periphery can be challenging to assess because compressed ovarian parenchyma will be present there. But in this patient, there was some thick, irregular thickness along the septations, as well as some of these echogenic areas, they showed vascularity. So that is something which is not expected from endometriomas. For the most part, they will essentially, the Rokitansky nodules, for most of the part, they are not going to show this much of vascularity of color Doppler. So now you can see that there are echogenic components, so B3 rule, and there is vascularity, which is fairly significantly high. Like I apologize for using the power Doppler here, but trust me, it was very high. So we applied it as 1M rule and 1B rule. So again, remember that you are not going to be able to classify this correctly. So unfortunately for this patient, there were multiple serial follow-up ultrasounds because of the fact that it was recommended that it's just an echogenic component, it's going to be benign, so let's just do a follow-up. But on one of the last ultrasounds, one of the radiologists picked this up and they recommended, no, this patient needs further assessment with MRI and probably a gynecology consultation. The CA125 in this case was 1073 Ku per liter. So remember, it was very, very high. Dermoids won't have that, right? So that was assessed and it was excised. So it turned out to be a low-grade serous ovarian carcinoma of the right ovary, but unfortunately, the patient also had peritoneal metastasis. I'm going to show that to you in the next slide. So the key point to understand or remember in this case is color flow in the echogenic shadowing solid component is discordant with the diagnosis of a dermoid cyst, right? Typical benign dermoid cyst won't have that. It is important to review all iota simple rules to avoid premature conclusions and labeling certain lesions as benign when they're technically not. So systematic evaluation is the key. So let's look at the histopathology of this patient. So as I told you, the patient had peritoneal disease. As you can see on this actual T2 image, there is peritoneal disease along the liver capsule. And then on high power histopathology image here, this is just a H and E stain. The reason why I'm showing you this slide is not to discuss about pathology per se, but see all of these violet, purple, or blue appearing areas. So dystrophic calcifications are going to stain like that. So these are nothing but samoma bodies, which can be seen with some of the papillary neoplasms. So remember this, one of the pitfalls that you can easily land into. So apply the 10 simple rules systematically in these cases. Case number 6. So we have this axial transabdominal grayscale ultrasound, which shows that there's a large solid appearing lesion there. So it was a 6 centimeter ovarian irregular solid mass, and it was actually picked up on a staging CT performed, which was for gastric carcinoma. So anyways, they saw the adnexal mass, we did the ultrasound. On ultrasound, you see very high vascularity. We gave it as a color score of 4. So now you have one M rule and another M rule here, right? So 2 M rules. So one is irregular solid tumor, and one, it is very strong blood flow. So based on these 2 rules, we can safely classify this lesion as malignant. So remember, 1 or more M rules, it is going to be malignant. So one key factor to remember here is that patient had a gastric carcinoma, and this was a staging CT. So final histopathology was a Kirkenberg tumor from gastric carcinoma in this case. The reason why I included this case is that even for these metastatic lesions in the ovary, you can technically have the same outcomes as the primary adnexal neoplasm. I mean, they recommend that we should not be using them when we're suspecting a metastatic pathology, but this case is just to show that how well the simple rules can perform even in case of metastases, because the grayscale and color Doppler features are going to be severely abnormal even in these cases. So the key point here is that whenever you see a solid mass with highly concerned and very high vascular flow, it is highly concerning for malignancy. So you can see there in this axial portal venous phase CT image that this is the gastric wall thickening in keeping with the carcinoma. And on this coronal portal venous phase, you see that there's lots of ascites, peritoneal carcinomatosis, and Krukemberg tumor involving the ovaries there. So again, remember, cancers of GI primaries can present with Krukemberg metastases. Like we see so often that usually women of childbearing age, they will present with Krukemberg metastases more often, and they will have really large, very, very solid appearing ovarian masses. And a search should be made to exclude a primary neoplasm in the form of a colonic carcinoma or gastric carcinoma. Case number 7. So you see that there is one grayscale image here on the left side and one on the, on the right side and one on the left side. The one on the left shows you a large ovarian mass, and you also see lots of ascites there. And on colored upper, you definitely see some vascularity. So the way it should be described is that I'll give you the dimension. This is 12 centimeters. So this is a multilocular solid lesion with more than 4 irregular solid components. As you can see, one of the components is here on one of the walls, but there are multiple other areas in the lesion as well. And these show increased vascularity. We gave it as color score of 3. And then in this patient as well, CA125 was elevated. As we were doing this ultrasound for this patient, we also saw that patient had ascites. And in one of the axial ultrasound images through the right flank, it shows that the patient has peritoneal disease, right? So when you see this, what is the likelihood of a benign neoplasm presenting with a peritoneal carcinomatosis? 0, none. So when you see this, you have to start thinking about malignancy. So now what you can do here is definitely the patient has ascites, which is a malignant feature in this case, and patient also has an irregular solid tumor, which is more than 10 centimeters. So you can apply 2 of these M rules, but none of the B rules. So this is essentially in keeping with a malignant process. So patient underwent a staging examination, and the staging essentially showed you, remember we saw one of these peritoneal deposits here. We see that on this coronal CT scan as well. And in the pelvis, you see this large irregular multilocular solid lesion with enhancing solid components. So when adnexal lesions appear clearly malignant ultrasound, a targeted assessment can be made for additional sonography findings such as ascites if you see any peritoneal disease elsewhere, because that can just expedite staging process for this patient. Case number 8, which is the last case of these this multimodality assessment or multi-imaging library. This is again very interesting. So you see this transvaginal ultrasound image, which shows you that there is a large mass, as I have labeled here, and this is the ovarian parenchyma, which is just adjacent to this mass. Whenever you see this kind of appearance on transabdominal transvaginal assessment, you have to make sure whether this is arising from the ovary or not. And to do that, you can just plain and simple, you just apply a little bit of pressure at the point where these structures are close to one another and try to see if the ovary separates from the mass. So this is at rest or normal. And when you put pressure, if it was not arising from ovary, the ovary will be pushed on one side and the mass will be on the other. But in this case, it did not. So it appeared as if it was arising from the ovary or within the ovary. So the patient had a history of left hand Merkel cell tumor, just to add it in one of the different, one of the clinical aspects to remember what you're dealing with. And the patient had metastatic left axial lymphadenopathy, which was 3 years later. At the same time, when we were doing staging CT, we discovered the patient had this adnexal mass on CT, right? So that's why the ultrasound was referred. So we see that the patient has a left adnexal irregular solid mass measuring 5 centimeters, and the mass is inseparable from the ovary, and it shows moderate vascularity. So it does not light up like some of the other ones which we saw earlier. So now what M rules and B rules you can apply? So definitely it is an irregular solid tumor, but none of the other B or M rules can be applied. So you can safely say that it's probably going to be a malignant process just based on having at least one M rule. So the patient underwent an oophorectomy, and final histopathology in this patient turned out to be a Merkel carcinoma metastasis in the ovary. So Merkel cell cancers or Merkel cell carcinomas, they are very aggressive and they can basically metastasize anywhere. And then dynamic assessment is very important with ultrasound, because you want to exclude the possibility that maybe you're just dealing with a broad ligament fibroid, or maybe it's just a pedunculated fibroid which sits close to the ovary, because in those cases, if you exert pressure, the ovary will separate from this lesion. But if it does not, then you can be pretty certain that it is arising from this lesion. So that is a very important point to remember when you're doing dynamic assessment. So just for the sake of further assessment, the patient also underwent a pelvic MR examination. So this is a dynamic assessment. As you can see in the earlier arterial phase, the solid component of this lesion does not enhance, and it just shows this gradual filling in as we go to some of the delayed phases of acquisition. And this is still below the level of enhancement of the myometria. Right, so the curve or dynamic enhancement curve, that is what you have to discuss in MRI ORADs. So what does it look like on histopathology? So just for the sake of discussion here, remember, like, these Merkel cell tumors are very, very aggressive lesions. They have a very high nuclear to cytoplasmic ratio. As you can see, these like dark stained nuclei, and there's hardly any cytoplasm. And you can see these multiple apoptotic bodies just to show you high turnover of cells. And you also see, if you're depending on what kind of screen you're seeing, but some of these nuclei, you can see that they are kind of like small stippled areas within them. This appearance is called a salt and pepper. You can also see this with neuroendocrine tumors. So just to show you that it is such a high aggressive or high grade appearing neoplasm. And remember, this patient presented with an axillary met 3 years down the line from the first excision of skin lesion. And now the patient also has adnexal and ovarian metastases. So in conclusion, so just by discussing about these 8 cases, we basically talk about how simple rules can be applied in clinical practice. This tool can just increase your confidence and accuracy in categorization of adnexal lesions as benign, malignant, or inconclusive. When it turns out to be inconclusive, you have to be more vigilant and really decide whether you want to recommend further management, you want to do any blood workup, you want to do any MRI examination, or want to see a gynae or gynaecology person assess them first. Systematic application of IOTA rules can avert potential pitfalls, as we saw in one of the cases when it was labeled as echogenic material and caused as benign, but when it turned on the color Doppler, the vascularity was very high. So systematic application helped to further assess that lesion, which turned out to be a low-grade neoplasm. Another thing which you can do to improve your adherence to lexicon and systematic application is use of templates. It is fairly easy to find some of these templates online. If you're not able to find, you can easily create one. If you don't use voice recognition softwares, you can just create your own templates on Microsoft Word. It is fairly easy to create pick list options there if you go to developer tools on Microsoft Word. In terms of limitations, many lesions may still remain as not calcified, right? Because we saw that there were multiple where one B rule and one M rule, or none of the B or M rule applied. Those can be not classifiable. And then these can be include sometimes large dermoid cysts, maybe an endometrioma, because they are not typical in some of the instances. And in those cases, you have to follow them up with either MR and do further diligence. Risk stratification and recommendations for further imaging evaluation is not clearly defined as per IOTA, but as we move down, the IOTA ADNEX model and the ORADs talk about those things in much detail. So for further readings, I have just put down some articles here. Some of the ones you can just clearly go to IOTA website and just access some of the published literature there. It is fairly easy to access that information, and it is very easy to digest. It's a very nice pictorial article that they have published online. So make sure that you go and check them out. These are my references, and thank you. So I'm going to just quickly go to Q&A session, see if there are any questions there. So if you have any questions, we will be able to go over them. So let me go back to question. I think there's one question here. Why are we studying IOTA rules when we have better classification system as ORAD? So that's a very relevant question. So the reason why we started, as we discussed, Mitusha was talking about a series of some of the body imaging sessions that we want to do. Some of the centers where ovarian neoplasms and cancer surgeries are not easily available, and even now, I still do see a lot of ultrasound reports which are just complex and complicated. So step one is starting with lexicon. The lexicon for ORADs is based on IOTA, and it's basically amalgamation of two different, not two different, but like just built on the basic lexicon which was described by the IOTA, and that's the reason why we described starting with the IOTA terminologies here, and we will build on this in the future. So it is very, very important to understand that it may be very easy to write a report saying that it's a complex cyst and just recommend the patient to see a surgeon, but not all complex cysts are going to be cancers and not all complex cysts will need surgery. And that's the whole idea behind these lexicon terminologies and risk assessment. So remember, IOTA classification with 10 rules will be just a very quick and easy assessment when you're at the console scanning the patient, which will help you decide in your head what you want to do next. So for example, if you're doing the ultrasound, as we saw in one of the cases today, that the patient had a lesion which looked suspicious like this. And then you saw, okay, the patient has ascites. So when you thought that, okay, this lesion is definitely going to be malignant, so now you make a more thorough search with ultrasound to find this peritoneal deposit. So it's very easy to use these simple rules, and that's why they're called as simple rules, and they just help you arrive at a conclusion faster than ORADs, or faster than you have to go back, search literature more, and then come back. So when you're at the console, maybe you want to give a quick thought into your head what you want to do next. It really, really helps you. So there is one question here, how to differentiate between compressed normal ovarian tissue from solid lesion and normal ovarian vascularity from increased vascularity. So that's a very good question. And the reason why it is really important to understand that is that physiological processes in ovaries are fairly common. One of those is our question here. So let me go to that question first. I think it's at the start of this session here. Okay, there. So now, if you look at these 4 images, option number C, or the case number C, as you can see here, is a small benign appearing lesion here, right? So the way we will describe it, if it was to be described, is a unilocular cyst, and there are no septations or papillary projections or solid components. In this case, it's for just a normal follicle, but you can see that at the periphery of the follicle.
The slide, the thank you slide is projecting.
Oh, okay. Sorry.
Reshare, I think it has got stuck there.
Now, I think now
yeah.
Okay, so this was one of the questions that we discussed earlier today. So we see that there's this anechoic cyst, and if we were to describe this, you could have just called it as a unilocular cyst, no septations, no solid components, or no papillary projections. But nonetheless, this was nothing of that sort, but just a benign follicle. But in case of benign follicles, you can definitely see that the ovarian parenchyma or ovarian stroma, it just gets compressed to the periphery. One of the simple tasks, or one of the simple tests that you can do when you're at the console, look at the patient's other ovary. That just gives you a very good comparator, or an internal comparator, of how the ovarian tissue is going to look like for that patient. In terms of vascularity assessment for the ovarian vascularity and how to differentiate that from increased vascularity. So remember that the ovarian tissue may or may not show you a lot of vascularity. As you may remember, like you may be seeing a lot of patients who come through ED for rule out torsion. If you scan 10 different patients, each one of them is going to show you variable vascularity in the ovaries. You're just trying to rule out whether there is arterial or venous insufficiency when you're putting your pulse Doppler or pulse spectral assessment. So the ovarian vascularity is going to be quite variable. The goal of IOTA terminology by assessing color score is, number 1, to arrive at a simple conclusion, whether it is color score 1 or whether it is color score 4. 1 is very easy. No vascularity, it is going to be color score 1. 4 is also going to be very challenging sometimes, but you definitely see that the papillary projections or solid components, those are the areas where you want to assess the vascularity. It may or may not be different from the adjacent ovarian parenchyma. Sometimes it could be maybe slightly confounding when the adjacent ovarian tissue is highly vascular, but the likelihood of the solid component being higher in vascularity from the ovarian parenchyma is what we are dealing with for the most part when we say that it is color score 4, because that is the area of neoangiogenesis. There is carcinogenesis happening there. So that is going to attract more vascularity, which is definitely going to be more than the adjacent ovarian parenchyma. So I hope that answers that question. And just to quickly go over one of the quiz questions that we had, how to describe. So we already looked at this lesion, and as it was described correctly in the session today, in one of the options, it is basically a multilocular cystic adnexal lesion with multiple low-level echoes. And this lesion, at least in this image, there are no papillary projections or solid components. Let me just check. Yeah, there are no questions on the YouTube chat feature as well.
There is just one question, definition of complex and complicated cyst, like what exactly is the difference?
So Yeah, so that's a very good question. So basically, IOTA or ORADs, they don't want us to use these terms anymore. We just have to define them as unilocular cyst with low-level echoes, unilocular cyst with solid component, irregular solid area in the cyst, unilocular or multilocular cyst with papillary projections. So basically, we are just trying to use, so an analogy to this will be, say, in BIRADS, when we are assessing breast lesions with ultrasound or even with MRI or maybe even with mammogram, what we have to use is the lexicon terminologies described there. So you can just say that, okay, there is a complex breast mass, but no, it is a spiculated breast mass and it contains suspicious microcalcifications, which could equals to complex breast mass or suspicious breast mass, right? So it's basically a similar analogy. They're not encouraging us to use the complex and complicated terminologies. They want us to use more standardized terms, such as you have your, let me just get it here. Yeah, such as these. So we are using either unilocular cyst, unilocular solid cyst, multilocular solid cyst. It has low-level echoes, it is anechoic, it has papillary projections, it has irregular solid component, the lesion is totally solid, and that is the way we should be describing them, because that helps us apply these rules as well as apply the ORADS classification system. Any other questions? I think there is something. No, there is nothing on the YouTube as well.
So I think you have made things pretty clear for them, and your approach was quite systematic. So I think the doubts have got cleared. So right now there are no questions.
Yeah, so basically what we did here today is that we discussed about IOTA terms and definitions and how we can apply simple rules. So remember, these lexicon terminologies essentially created the further advances into creating IOTA ADNIX model as well as the ORADS risk stratification system. So we will be discussing about ORAD sometime in the future, and at that time we will be referring to these similar lexicon terminologies. They may be adopted completely or maybe tweaked a little bit, but the philosophy kind of remains the same. We have to use systematic approach and we have to use lexicon terminologies so that we can apply these rules and we can apply the risk stratification system.
So I think with this we can conclude today's session. And thank you, Ameya, for this wonderful session and taking out time for all of us. And we'll be meeting you online again next week with the breast imaging masterclass. And also we're looking forward to more of such sessions. So we'll be putting on various groups and social media platforms about the upcoming sessions and updates by Dr. Ameya Kulkarni.
Thank you, Indian Radiologist, for this amazing opportunity, and have a good day, everyone. If you have any questions, you can always reach out to me. I have given my email address on one of the thank you slides there, so feel free to reach out to me.
So thank you everyone on a Sunday morning being with all of us and discussing this important topic. I have again pasted the links to registration for various master classes and MRI teaching course on the chat box, and we'll keep the session live for next few minutes so that you can take those links if you want. All these sessions are also there live as well as recorded on YouTube channel of Indian Radiologists. Do subscribe to the channel to see more of such educational videos. And the links are also shared for the upcoming masterclasses. Dr. Ameya has shared his email as well on the chat box. So if somebody wants to connect, you're most welcome. Thank you once again.